and we will start about the preoperative planning, how to plan for a patient with a protrusio acetabuli, especially the center rotation of the hip, as well as some technical consideration during operation. And this is a case presentation. We will start it now, and then we will solve the problem later. So anyone can share his ideas. This elderly or middle-aged female, sorry, she's 65 years old, presented with acute injury of her right hip due to MVA. Apart from this is an isolated fracture, an isolated injury at the hip. She has become immobile while she was previously before fracture. She was free, independent, and very good health. Apart from the hypertension, she has an anterior hip pain, and also she cannot move her leg away. So if anyone can participate to describe the X-ray, please raise your hands. Okay. Anyone can define what happened here in this X-ray? Please raise your hand in order to see you, and then I will give you the mic, please. Unmute all. حسين شنو رأيك؟
عم دكتور سنان تسمعني؟
اي طبعا اسمعك كله زين.
إيه.
Yeah, you have the mic, and please describe what you see in the X-ray.
Plain X-ray of the pelvis and both hips, showing advanced OA of right hip joint. Also, there is two fracture line, one in medial wall of acetabulum, and another in left pubic rami.
Okay.
Also showing advanced OA and avascular necrosis, يعني increasing density of the femur head.
Well, this is acute fracture, my dear. There is no advanced osteoarthritis, but you can see that the head of the femur is medialized, and you can see this line. Yes. You can see this line from the lesser trochanter of the right into the right side. This is the line where there is a significant shortening due to centrally dislocated hip, right?
Yes.
Okay, thank you very much. Thank you very much. So we will learn how to appeal this X-ray and how to deal with it later on. And what are the considerations if you are going to do some sort of surgery? What are the considerations you put in your mind before to take down this hip? And we will see what are the techniques during hip replacement, if the choice is a replacement, of course. So thank you very much, and we will now proceed to our presentation. So as an introduction, the protrusio acetabuli, aka erythrocatadesis, or what is called autopelvis, it is a deformity of the hip joint when it is involved the invasion of the lesser pelvis due to medial acetabular wall defect that is associated with medial migration, as you see in the picture before, of the acetabular wall, of the migration of the femoral head. It is described by the German pathologist William Otto in 1842. So there are two types, primary and secondary. The primary, as you know, is an idiopathic, and secondary, there is the protrusio caused by one of multiple conditions. And you know that the primary is a form that it is developmental condition, the hereditary either or racial influences. It occurs in early adolescence or in patients, in young age patients with before the thyroid cartilage has been closed. So the deformity after that will be significant and more symptomatic as soon as the patient will have symptomatic, as soon as the patient will have developmental mechanism, or adaptive changes or degenerative changes. For the secondary, secondary causes, there are many causes, as you can see in this table, in this box: infectious, inflammatory, metabolic, neoplastic, genetic, and also the traumatic. But however, you can divide it in simply two types: either inflammatory etiology or non-inflammatory. The inflammatory etiology, it leads to destruction and weakening of the surrounding bone of the hip that result in migration along the joint reaction force, which is medial. Okay. However, the non-inflammatory that are due to qualitative deficiency, and there will be a growth disturbance and developmental abnormality, like these connective tissue disease and metabolic disorder, as you see it in this table. So the resultant that we have a weak medial wall, and then you have a strong superior wall. As a vector force will occur, the joint will be invaginated into the medial side, into the lesser pelvis. And this is the main pathology. For diagnosis, we know that, first of all, the history, family history, and history of a trauma. Usually you ask about if there is no traumatic causes, they have neuromuscular disorders, and so on. During clinical examination, you have to see that it is an activity-related pain, clinically presenting as anterior hip pain, activity-related, with stiffness of the hip joints, especially the abduction and internal rotation, as well as there is a Trendelenburg gait or Trendelenburg test positive. For radiographic parameters, we have very important parameters when you do a standing anteroposterior and lateral view. You can also figure out. There are sometimes a Cook-Savara, and there is also shortening of the affected side, and there are degenerative changes in severe cases. However, you can use the interpterodrop line, as you see the picture on the left side. This interpterodrop line, perpendicular line from the center of the hip, you draw it on the interpterodrop line. This is perpendicular. And then from the center point into the lateral edge of the acetabulum is another line. This line with the perpendicular one will form the central edge angle. This is angle of Weiberg, which is described by the orthopedic surgeon Weiberg, as he estimated that there is a over-covering of the acetabular wall on that of the femur, which is in acetabular protrusion more than 40 degrees. Another line is that the Kohler line, which is line, the angle is F. Now the line is A. If you see it in this picture, this is the Kohler line or ilioischial line. In the left side, which is called normal here, you can see that the head is away for about 5 millimeters from the inferior portion of line A, while in the other side, which is called the protrusio, the head is crossing this line. Whenever this is the head of the femur is across the line, this is called the protrusio. Some of the cases, there is no protrusio, but what is called coxa profunda. Coxa profunda means that the medial wall of the acetabulum is across the Kohler line, not the head, okay? And this is the differences. Again, as you see in this image, an epi view of the pelvis, it shows that the Kohler line is crossed by the femoral head in both right and bilaterally, right and left, all right? And this is the iliopectineal line also, which is crossed by the medial wall of the acetabulum. Another aid of the image is that the CT scan, which confirms the diagnosis radiographically. And you can see that this thinning of the acetabular wall. So regarding the classification or types of protrusio acetabuli, which is described by Charnley, he said that when it is mild, from 1 to 5 millimeter of crossing the head, distance from the head immediately away from the cochlear line, moderate 6 to 15 millimeters, and in severe cases more than 15 millimeters. So what about surgical principles here? Many of the cases in the early phase when they are young adults can be treated non-operatively. Sorry, yes. Especially by activity modification, weight loss program, physical therapy, and some analgesics, especially for the physical therapy, strengthening of the muscles in the hip flexors, abductors, lumbar spine also. Operative indication is that when you have a progressive symptomatic that affect the daily activity of life, and especially recommended only the total hip replacement. However, in young adults, there are some sort of salvage procedure in the acetabulum and or associated with the femoral osteotomy. So regarding the total hip, there are considerations that you have to take and put in your mind before taking down the hip. First of all is the hip center of rotation that must be restored to anatomic, more lateral and more inferior. As you see that in the pelvis, it is more medialized and superior. The acetabular cup rims must be adequately intact. Otherwise, you may have lose the adequacy of the rims and attachment of the cup. While the medial wall, you can leave it and put it in a graft, and you will see how can we do grafting for the medial side. Regarding the limb length, you can do limb length restoration, and this is a special entity when you have in bilateral. When you have a bilateral in a preparative planning, special consideration in contralateral hip must be taken up. So you can ask your patient for a consent, and you start from one side and you tell him that you're gonna have a longer limb than the other affected one. So as in the when you start to go for a scheduled or in the same session, you have to put in the same length. So here you can generally plan for a low-level femoral neck resection and avoid over lengthening by choosing a femoral component with an offset. Regarding the soft tissue contractures, there are many, and especially in adaptive changes occur. So you can have serial and regular releases of the soft tissue, and you will see that later. Regarding implant choice, the goal is to have a stable implant that restores the biomechanics of the hip. A porous coated or porous acetabulum or a cemented cup can be chosen. For the cemented cup, the graft must be inserted and with or without a mesh, and then you put your cement. After that, you put your cup. For increase the bony osteointegration, you don't rely on the void of the medial acetabular wall because it is too thin. On the other hand, a porous clustered cup can be used for bony osteointegration, as you have the periphery of the cup is well attached to the periphery of the rim, of the acetabular rim. In cases of if you have a defect in the superior or posterior, which is very vital to preserve it, you can have a flanged cup. Or if there is a porotic bone and a defect in the wall of the anterior or posterior, you can have a metal-backed augments or anti-protrusio cages that are used in severe defects. This is the metal back when there are deficiency. In this X-ray, the A marked by A, you can see a total hip replacement that is dislocated inside the hip, the femoral head forming a force here, and the cup is inverted into the medial, and all is medially dislocated with a severe deficient acetabulum. As in B, and this picture will show you that this is the augment that is used to augment the defect which is occurred in the superior and posterior side. Also, you can see this is a flanged cup that is used to prevent that prevents medializing the cup of the acetabulum during reaming, and you can see the grafts in both right and left. This is the flanged cup. You can put the polyethylene inside, or this is the anti-protrusio cage that can be put the cup of the acetabulum and polyethylene as well as the hip joint. So surgical technique builds. Regarding the soft tissue contracture, in very chronic cases, the following release can be done. After you have the approach in the posterior or anterior, you have to take down the anterior capsule in order to release it. And then the gluteus maximus, the posterior position, the posterior insertion of the gluteus maximus can be released. Partial longitudinal split of the abductors can be released also with a longitudinal splitting. And if it is still very stiff, you can do a trochanteric sliding osteotomy. All of these, you have to take care about the sciatic nerve, especially when the anatomy is distorted. We have to explore it. So after that, you reach the hip joints. What about dislocation? Unlike the total hip primary, it is called here difficult primary because dislocation is so difficult. There is nothing called dislocation because the head and neck all the way into the acetabular shell. So you have to excise first a portion of the posterior overhang in between the acetabulum in order to make your access to the knee joint, to the neck. So the posterolateral approach using a Kocher approach, whether you have to preserve or take down the piriformis tendon, the capsule, the posterior capsule can be done, or if you can see a bony ridge along the way of from the acetabulum into the inferior part of the neck, you have to excise this portion so that dislocation will be easy. However, if there is no movement at all, an in situ neck resection usually can be done. And this way, as you see in the first two webinars, we suggested that the neck resection, which is difficult, we do double osteotomy. We do one single osteotomy. You always take care about the soft tissue. You have to release it between the greater trochanter and the lateral neck of the femur in order to see where the neck cut will be. And this neck cut is estimated as in templating or 1.5 centimeter from the tip of the lesser trochanter. You do the neck cut, your resection, and then you do another one proximal to this resection about half centimeter. You take up one block from the neck and the femur can be retracted inferiorly simply. When the head is inside the acetabular shell, you can now put either a corkscrew after axial traction of the femoral hip in extension, and then a corkscrew can be inserted into the head and then pulled out. If the head cannot be pulled out, especially when the adaptive changes occur inside the head, you can do piecemealing in situ resection, and you can do it with a nebula. This is the Hohmann retractor. The curved Hohmann in this picture shows preservation of the posterior part and inferior part, especially if the transverse acetabular ligament. In superior acetabulum, you can put this Charnley or half pin in order to preserve the muscles above the acetabulum, and a curved one anteriorly in order to retract the femur away and go for the acetabular addressing. So avoid floor perforation with when you are removing the pulvinar, especially when we are talking about the acetabular addressing. The first of all is that there are many soft tissue as well. If you can see adaptive changes that occur between the articular surface of the head and that of the femur. So in regards here, you have to take very careful cleaning of the pulvinar and soft tissue inside the acetabulum. The aim after you address the acetabulum is a divergent rim, and you will see how. Reaming will be started from the larger size into a smaller size, unlike the primary hip. When we are going to do reaming, you choose the smallest one in the manufacturer, like for example 44 or 42, and then you ream the medial wall or the floor. Here, in such cases, you don't have to do it. You don't ever do it, actually. You do the largest one. Let's, for example, say in templating, or you can estimate intraoperatively, a cup size is 54. So you start reaming by 52, and then you decrease the reaming into 50. After that, you decrease the reaming into 48. You can see that in this sequential decrease of the reamers, you can take up the periphery of the acetabular shell in order not to maintain the reaming of the medial side of the acetabulum. After that, when you have reached the 48, for example, and the tip of your reamer is not attached to the medial wall, this is when you stop. For example, if you choose 46 and you put it inside and you see that it will ream the medial wall, you have to stop away. So you can see in the picture above, this is the sequential reaming when you have got the reamer only at the periphery, when the cup is convergent, and sequential reaming when you reach, for example, as we see the 48, it will not reach the tip, the upper right picture, it will not reach the tip of the medial wall in order to maintain this divergent side of the acetabulum. Then after 48, you will increase your reamer into 50, 52, and 40, and 54. This picture below shows that the medial graft, and we will take it into consideration, and there are principles how to put it with the bone cement and a flanged cup. So grafting first is the simpler, is the morselized graft incorporated inside the medial wall with the smaller head pushing. You put a smaller head, a trial one, and then you push your graft inside. Usually this morselized graft is preserved for less than 5 millimeter, or in mild cases of a protrusion. In case when you have a large defect or a large side of the protrusion, not only the morselized is enough, so you have to resect the head. If you have the head intact and you cut it with the neck, you make another cut, half the head, you remove the all articular surface, and then you put it inside the medial wall of the acetabulum. And this will be impacted by reversing reaming impaction, which means that we reach the number in reamer, for example, 46, and you stop it, you don't ream it. You bring this graft, the femoral head graft, and you put it inside the medial wall, and you bring this 46, the last reamer. Usually, the last reamer is put inside the graft and you do reverse reaming. This will incorporate the graft all the wall of the medial wall of acetabulum. Usually a morcellized graft, some of manufacturers bring with them a bone mill. Otherwise, if you don't have, it's no matter. The reamed part from the acetabulum and the part of the head from inside, you can do morcellization graft from nibla. If there is not enough, you can have either posterior crest autograft or a synthetic allograft, especially when a larger defect more than 10 millimeter in the protrusion, and adjust the templated trial cup with the new formed shell. After you put the graft, then the templated trial, you put it inside your new shell. Regarding cup placement, and take a consideration about the direction, abduction, and orientation, I mean, of the femoral acetabulum, of the acetabulum, sorry, during reaming. So you have to take it in consideration about the abduction and inclination. However, the cup placement depends on many sites. Ranawat suggested that this Kocher line and Schentel line, as well as the inferior border of the teardrop, is very best thing to have a landmark, especially when you have a C-arm inside the operation. Intraoperatively, the transverse acetabular ligament, if it is present, it is very indicative marker for the cup orientation. And last, the relationship between the cup trial rim and the acetabular peripheries are well seated into the medial graft, if it is from the center, and the rims are away from 2 millimeter from the periphery of acetabulum. As a postoperative, touchdown walking will start in the second postoperative day, and this will continue until 6 weeks for a partial weight bearing. You started partial weight bearing after 6 weeks until 12 weeks, 3 months full weight bearing without an aid. Regarding the outcome, in 2017, they suggested no prosthesis loosening or subsidence and healed of the bone graft without resorption in cementless total hip arthroplasty. Another study has suggested a very satisfactory results from 80 to 85% in cemented using morcellized bone graft. And this one is from Yasser Baghdadi at 15 years follow-up, another satisfactory results in the acetabular and femoral component. So regarding our case, here again is a 65 years old female presented with RTA, fracture of the medial wall of the acetabulum, the right side, and the pubic rami on the left. The pubic rami was treated conservatively, and we planned for the acetabulum to have a total hip arthroplasty. You can see the head is impacted about 5 millimeter away from the cochlear line, as well as there is discontinuity, minor discontinuity of the acetabulum. So we treated first conservatively of 4 weeks of skin traction, skeletal traction, and then another 4 weeks for bedridden with encourage non-weight bearing walk until this fibrosis will occur. After that, a total hip arthroplasty, we choose the acetabulum shell, which is the dual mobility cup. You can see, or you cannot, I don't think so, this is an intraoperative view where the head, I use it inside the acetabular defect, acetabular shell defect, and this is the final X-ray. When you can see this one, this outline away from the cup, this is the head, We use it to impact this graft from here to the inferior part, and we use a cemented type of dual mobility cup with a cementless stem. Thank you very much. I hope you enjoy this webinar, and I'm waiting for your questions. If you have it, please write it down in the chat. Yes, divergent cup, the question. When you have a divergent cup, you will have a hemispherical, not an oval shape. This is the aim. Dr. Mukhaled Walid, welcome. Does grafting is a must in protrusion stably? Yes, because if you don't have it, you will have again an oval shape acetabulum. This is a very, very difficult to have the acetabular shell or the cup implant to be incorporated, or there will be only about 50%. We may have increased this 50% of the attachment with the bone. So that's why we do grafting inside the medial wall in order to augment this defect, as well as to make the osteointegration in case of cementless cup or an interdigitation of the acetabulum. Dr. Hussein Zofi explained about the divergence of the cup. As you see, the cup of the acetabular shell, the native one, it must be opened, an open mouth. In cases of a protrusio, there will be an overhang over the femoral head and neck. So you can have, when you resect the neck, you cannot have much opened. It must be divergent, not convergent like this. So you have a sequential reaming in order to make it open mouth and hemispherical. So that's why we start from a larger acetabulum, acetabular reaming, and then you will decrease it gradually until you don't ream the floor of the acetabulum. وصلت الفكرة إن شاء الله. Dr. iPhone, what is the best surgical approach for these cases? Actually, surgical approaches is surgical dependent, whether anterior or posterior. I myself do posterolateral approach. There's no one superior at all about any. Many have suggested articles about lateral hardened approach, which is very easier, but me not. Okay, please to explain more definition of acetabular protrusion. Well, acetabular protrusion is that when you have it, as you see in the first lecture, it is the medial protrusion of the head and the floor of the acetabulum inside the inside the lesser pelvis. And per se, it is more than 5 millimeters than the cochlear line. So how about CT scan? Is it a routine investigation for those cases? Actually, if you have the case of traumatic causes, yes, it is a must. It is a routine because you have to know whether the defect, where is the defect, and where you can have the part of the, sorry, when you have a part of the defect and how large is it, in order to make these considerations first before operation. Templating first, and then you prepare yourself to augment these defects before operation. So CT scan, yes, it is a routine, especially if you have like rheumatoid arthritis, like the trauma causes, the secondaries. why not to try fixation of fracture? Regarding the case, yes, any indication for total hip replacement directly in the acetabular fracture. Not all acetabular fracture is an indication for total hip, my dear, especially when you have an anterior or posterior column or both. You have to try a fixation. Yes, this is a promising. But when you have only central dislocation of the femur, for example, from the lateral impaction, there is no pelvic ring fracture, and only the acetabular floor is a fracture, central dislocation per se. This one can be treated as a total hip, but not immediately. It is more than 6 weeks. Many suggested that the fibrosis will occur. However, the fixation of the medial wall of the acetabulum is so difficult to treat, especially when you don't have posterior wall fracture or posterior column. Thank you very much. Thanks a lot. If anyone has an idea about or participate the previous case, I'm glad to share your ideas about the case. Thank you very much. So, is there any questions further? I hope you enjoyed the webinar, and I think, thank you very much, Dr. Ahmed. I'm very happy. Well, thank you, Sarah. Thank you, everyone, for this sharing and attending this webinar. I hope next week will be the start of the total knee replacement as a principle, and first of all, the biomechanics. I will show you the schedule for the total knee. And if anything related to the total hip, we can repeat it later. This will be scheduled for you, and this lecture is recorded now, and you will see it in the YouTube channel. Thank you very much for participation, and have a good luck.